Hello, good afternoon, everyone. Warm welcome to you all for today's scientific session on evidence-based management of atopic dermatitis. With immense pleasure, I am happy to welcome Dr. Ramanjit Singh from Gurgaon. Needless to discuss about the Dr. Ramanjit Singh. He is such a personality. Just brief introduction about Dr. Ramanjit Singh. He is a dynamic cosmetic dermatologist leading the cosmetic and dermatology treatment of Gurgaon with his extensive experience of more than 20 years. He is also amongst the few cosmetologists who have brought the concept of laser in India. He is heading the state-of-art Duncos skincare clinic at Gurgaon and is also associated with Medicity the Medanta as a senior consultant department of cosmetology and dermatology. His clinical focus and expertise are in clinical dermatology, acne and acne scar surgeries, laser therapies for acne scars, chemical peels, non-surgical facilities, etc. In addition to the routine clinical work, he is actively involved. Sir is actively involved in various academic and research activities, comparative studies of medical and surgical modalities in the treatment of vitiligo, role of cryolush in acne, psychosocial effect of psoriasis on individual, and he is authoring the book of acne and scars and textbook of medical emergencies dermatology chapter are some of his contribution toward the medical society. He is the organizing president of Face Aesthetic Dermatology Society and has been organizing yearly academic workshop for budding dermatologists. He is an active member of International Society of Dermatology, Cosmetology Society of India, as well as Indian Association of Dermatology, and also life member of Association of Cutaneous Surgeons of India. Without taking much more of your time, I'm directly handing over dais to Dr. Ramanjit Singh. Sir, over.
Thank you for your kind words. Today we are here to discuss something about atopic dermatitis. Atopic dermatitis is a very common condition which affects childhood. It can affect any age of life and which can be a really debilitating and harming for mental. It can take a definite mental toll for patients suffering from atopic dermatitis. Now today we are here with the objective to review some of the main pathophysiological mechanisms involving in atopic dermatitis, which include skin barrier defects and immune dysregulation. We also have to review the role of emollients, anti-inflammatory agents, wet trap therapy and immune-directed targets for biologic therapy. Coming to the pathophysiology of atopic dermatitis, basically all three mechanisms are involved. There may be loss of skin barrier. Skin barrier is harmed, which gives that may be because of the defect in immune system, or there may be some amount of systemic involvement which can give rise to atopic dermatitis. There may be skin barrier failure, or there may be a failure of immune system. These days, off late recently there has been evidence that it is certainly autoimmune disorder. So thereby, once immune system is dislodged, it can definitely lead to exacerbation of the atopic dermatitis. Atopic dermatitis is one of the most common skin disorders affecting 20% of children and 1 to 3% of the adults. Its onset at the age of less than 1 year is 60% for most children are affected. This reaches about 85% to 90% by 5 years of age. It shows various cycles of exacerbation and remissions. There are, however, poor prognostic features which may include family history, early onset of the disease, female gender may be most commonly affected, or the coexisting atopic triad, which includes asthma, atopic dermatitis and allergic rhinitis. 90% of the cases are seen in less than 5 years of age, and in children about 10 to 20% is the prevalence rate. Moderate cases may be about 67%, mild cases may be about 67%, 23% of them may be coming to the moderate variety, and in severe forms it may go up to 7%. So 80% of the atopic dermatitis persists from early childhood to adulthood. However, 20% can get some amount of remissions at any part of the age. Clinical diagnosis is by clinically, and there is no lab tested diagnosis for diagnosing atopic dermatitis. Severe pruritus with eczema, with xerosis, with atopy or raised IgE levels are enough to give a diagnosis of atopic dermatitis. However, essential for diagnosis is only two factors, which is pruritus and eczema. Differential diagnosis may include contact dermatitis, seborrheic dermatitis, scabies, psoriasis, ichthyosis, photosensitivity, skin lymphoma, primary idiopathic dermatitis, or more so erythrodermia. Now we have to evaluate the patient for better treatment. So we have to find all the myths and barriers. We have to find common triggering factors which trigger atopic dermatitis in your patients. We have to investigate sleep disturbances, and we have to also investigate psychological affection. Quality of life for atopic dermatitis patient bringing back to normal is the most important part of treating a atopic dermatitis patient. Clinical features, as I have already told you: pruritus, intense pruritus, xerosis, which may be because of excessive dryness, or apart from that, rash on the face, especially on the face, especially in children, is enough to give a diagnosis of atopic dermatitis. Patients with atopic dermatitis experience debilitating effects that impact day-to-day functioning. There may be intense pruritus, which may be frequent, and there will be excessive itching. There will be sleep disturbances in such patients. Patient won't be able to fall asleep, or he may be awakening from sleep at night. There may be persistent flares, skin infections because the skin barrier is raw. So such patients can easily go into skin infections. It may be in the form of bacterial, viral or fungal infections. Then there may be other comorbidities like atopic diseases. Then apart from that, there will be impaired quality of life. Patient won't be socializing, he'll be aloof, he won't be going to his office, he won't be attending schools. So all these things, keeping in mind, we have to reduce the disease burden of atopic dermatitis. Approximately 70% of the population consider themselves to possess the characteristic of sensitive skin. 50% of these patients demonstrate uncomfortable symptoms without accompanying visible signs of inflammation, and there may be increase in prevalence of the sensitive skin. Many trigger factors like physical triggers, it may be triggered by excessive cold climate, chemicals involving cosmetics, environment, psychological stress, or at times hormonal stress can also lead to triggering of the factors of atopic dermatitis. Most common chronic inflammatory dermatosis in the pediatric group we have found is atopic dermatitis. Prevalence is about 5 to 20%, and age of onset of all atopic dermatitis by age of 5 years we have seen in about 85 to 90%, and about 10 to 40% of the cases are moderate to severe variety of atopic dermatitis. So now coming to the disease burden and seeing where it stands among the other pediatric illness, this we find that eczema, which is atopic dermatitis, is very common in the pediatric age group. It is more common than asthma, more common than urticaria, more common than any other renal diseases. So that needs to be taken attention of all the dermatologists. Atopic march refers to the age-related sequential development of allergic symptoms frequently associated with raised IgE levels to common environmental and food allergens. Early onset of atopic dermatitis is often first manifestation followed by asthma or allergic rhinitis, which is again very common in atopic dermatitis. Now, main treatment goals when we have to treat a patient of atopic dermatitis, we have to see that how we can prevent exacerbations. We have to treat comorbidities. We have to try to treat all the complications, and with all this keeping in mind that there should be minimum adverse effects of whatever medicines, topical or oral, we use for such patients, and we have to definitely improve the quality of life. Treatment options, non-pharmacological is the most important stay for treating patient of atopic dermatitis. Emollients and emollients repeated and regular use remains the mainstay of non-pharmacological treatment for atopic dermatitis. Skin care again is very important. We have to give what instructions we have to give to the patients, wet wraps, all these form non-pharmacological treatment options. Apart from that, we have other topical agents like steroids, calcineurin inhibitors, antimicrobial agents, and crisaborole wherever required. Patients are recommended that they should keep their nails trimmed. They should moisturize their skin as frequently as possible. They should apply a moisturizer right immediately after bathing, and they should reapply moisturizer twice a day even before going to bed, so that at night time they don't experience itch and they don't scratch and they don't activate the itch scratch cycle. Baths, when it comes to bathing, warm, hot, normal hot water baths, not very hot water should be advised. Mild soap should be advised with normal pH, and the bathing time should be limited to just 5 to 10 minutes. Otherwise, more of water, more of excessive dryness, more of problems, and patient should be asked to pad dry the skin to restore normal barrier of the skin. Even the for bathing, bath soaps, whatever used, they should be fragrance free and they should be of normal skin friendly pH. So this is a picture of typical atopic dermatitis where we see in all textbooks, and this is, if it is superadded with bacterial infection, we find a definitely flare, and you can see how agonized the child is because of the superadded bacterial infection. Now, immunosuppressants are very important to treat atopic dermatitis. Various types of immunosuppressants are available in the market. We have off-shelf preparations which are normally not available in other countries, but here we have, and because of this we end up with many complications, many problems. Now, treatment, topical calcineurin inhibitors form a major part of immunosuppressants, and it forms a major part of treatment of atopic dermatitis. Apart from this, topical corticosteroids are also used, but to some extent they are definitely not recommended in normal children, or they are not recommended in soft areas. If this apart from this, if this doesn't work, then we have to go for oral cyclosporins. Oral cyclosporins are definitely helpful, but again the limitations are there that they cannot be used for very long time. Topical crisaborole is another good immunosuppressant which has also been successfully used for treating atopic dermatitis. Now, basic management plan, we have to see if a patient doesn't come with any lesions and patient is on maintenance, then basic management includes skin care where moisturizers liberal use is required, warm baths or showers using non-soapy cleansers, usually once a day, followed by moisturizers. Even plain coconut oil forms a wonderful moisturizing regime for patients of atopic dermatitis. And other important part for basic management is to avoid trigger factors. Proven allergens and common irritants, example soap, wool, temperature, extremity, should be avoided so that patient doesn't get a trigger of atopic dermatitis. In mild cases, skin care regimes certainly remain the same. We have to moisturize, liberal use, frequent use, warm baths, showers, soap cleansers, non-soapy cleansers are recommended, and which may be followed by moisturizers 2 to 3 times in a day. Aseptic measures using dilute bleach baths are also recommended, and antibiotics if in case patient is going for infective phase. Trigger avoidance is again very important, where we have to avoid allergens and we have to advise regarding clothing of the patients. So non-lesional atopic dermatitis, skin care and trigger avoidance; mild, skin care, antibiotics and trigger avoidance. And rescue is definitely topical corticosteroids or calcineurin inhibitors. Now, in moderates, as we have seen, then maintenance therapy is to be by giving low potency topical corticosteroids, which may be given once a day or twice a day, but we cannot prolong the duration of such treatment, and medium potency however can be given just one to time and only on weekly basis. Maintenance could be again switched over to topical calcineurin inhibitors like premcrolimus or tacrolimus. In severe forms, however, the management changes. There are various formulations and various therapies which are available of late. We have phototherapies where UVA and UVB rays are given to the patients. They help in reducing the lesions. Dupilumab is a very good therapy for giving in severe cases. However, systemic immunosuppressants like cyclosporin, methotrexate, mycophenolate, mofetil, azathioprine or corticosteroids again have to be used in severe cases. They have to be restricted only into the severe form of atopic dermatitis. And if the form of atopic dermatitis is very severe, we should refer it to a specialist who can take care of these further skin infections. So mild to moderate, we have to going from mild to moderate, we have to increase the dose of topical corticosteroids. We have to add tricalcineurin inhibitors. We have to add crisaborole also, and these are various options which can decrease the severity of the disease. Moderate, going from moderate to severe, we require phototherapy, dupilumab, systemic immunosuppressants, as I have already discussed and I have already told. Now, various newer biological agents have also come into existence. They have come into play. Various studies have come up which are supposed to be very, very safe. However, only limitation is they are way too expensive, and for normal people to get biologic agents for treating atopic dermatitis is very, very difficult. So we have to restrict ourselves depending on the population, what population we are dealing with. And if we go for any of these biologic agents, we have to get basic clearances from the respiratory department, so that there shouldn't be any flare of the tuberculosis, or there may be not any underlying cause which can be flared by adding biologic agents for atopic dermatitis. Non-pharmacological, as already discussed, include good moisturizing creams, barrier creams, bathing practices, and topical agents, corticosteroids, calcineurin inhibitors, antimicrobials, or crisaborole depending on the severity of the disease. In severe forms, already discussed, phototherapy, cyclosporin, azathioprine, methotrexate, mycophenol mofetate, systemic steroids, and dupilumab. Now, among all these topical calcineurin inhibitors, they form a very, very important part for treating atopic dermatitis patients. It may be moderate form of atopic dermatitis, or it may be severe form of atopic dermatitis. They are considered to be very, very effective and very, very safe, and it can be a big corticosteroid sparing drug. So coming to topical corticosteroids, various compounds and formulations have been formed of various potencies, but while treating with corticosteroids, we have to be very, very careful. We should not treat with stronger corticosteroids on sensitive areas. However, on areas involving palms and soles where skin is very thick, we can definitely use safely corticosteroids, and to a longer duration. Many different compounds and formulations have been seen, different potencies and short-term treatment for atopic dermatitis flares, because flare is known to be difficult part of atopic dermatitis. So whenever there is a flare, we have to go for corticosteroids. It has to be, however, used only for short-term treatment of atopic dermatitis flares. We have various side effects which include skin atrophy, skin barrier impairment may be there, and where patient may be more prone to getting skin infections, bacterial infections. There may be also increased risk of skin infections because there will be lowering of immunity of that particular patient, and apart from that, at times can lead to tachyphylaxis or corticophobia. Sensitive areas like lid and like neck region, we should always be avoiding glucocorticoids. However, when it comes to palms and soles or back areas, or to some extent abdominal skin, we can definitely use corticosteroids, but again to very limited time period. Topical corticosteroids, it again, as I've already said, it decreases the thickness of the stratum corneum. In sensitive areas, glucocorticoids can facilitate the penetration of allergens, and exacerbation of eczema may have been noticed, and there has been definite rebound after discontinuation of the glucocorticoids. So topical calcineurin inhibitors was a major development in treatment of the inflammatory skin disease after the introduction of the corticosteroids, which was done about 50 years back. It has a dual mechanism of action. It decreases inflammation, and also it decreases the pruritus along with inflammation. Topical corticosteroids versus topical calcineurin inhibitors. If we see there's a very selective mechanism of action of pramcrolimus and tacrolimus, which is topical calcineurin inhibitors. They act on T lymphocytes, mast cells, and basophils. However, if you see corticosteroids, they act on different parts, and so they are causing more harm to the patient if you look at it long-term modes of treatment. Pramcrolimus 1%, it improves skin barrier, so there's formation of regular and continuous extracellular lipid bilayer structure. However, if you are treating same patient with betamethasone, there will be irregular skin barrier and irregular and disrupted lipid bilayer structures. Pramcrolimus may be able to restore the epidermal barrier by its effect on expression of genes which are essential for normal skin barrier function. Betamethasone, in contrast to pramcrolimus, has shown to cause a significant reduction in expression of amylocurine and small proline-rich proteins which bind to ceramides. So, this is beyond comparison. Betamethasone is definitely more a harmful drug if you check on these calcineurin inhibitors, and there are various important factors which has led to dermatologists believing in more in these calcineurin inhibitors. Pramcrolimus restores the normal skin barrier, which is seen by this picture, whereas after betamethasone there has been an irregular and disrupted lipid bilayer structure. This may, however, explain the lack of restoration of the functional stratum corneal layers observed by topical corticosteroids. Pramcrolimus can be effective in restoring the epidermal barrier in patients with atopic dermatitis with minimum side effects. And similarly here, this shows the acceptability of the patients who are being treated on pramcrolimus versus corticosteroids. We see there is much more easy application of pramcrolimus. There is less of concern regarding the use of pramcrolimus in sensitive areas. Tolerability is much more better. Improvement of quality of sleep is much more better. Improvement of quality of life is good. Then it also gives us feeling of well-being to the patients who are on pramcrolimus, and there is definitely a flare prevention by using pramcrolimus, and it also has a good disease control. So various studies had been done, and largest ever comparative study of atopic dermatitis shows that pramcrolimus is definitely a better option for treating a patient with atopic dermatitis. Now coming to the signs and symptoms for dry skin, bland emollients only are required. Apart from that, if there is severe itching or redness, bland emollients, at the same time pramcrolimus has to be added, and if there is disease exacerbation, again we have to add topical corticosteroids, plus we have to arrange a visit to the doctor. And if there is a bacterial and fungal or viral infection, superadded infection, we have to add systemic topical antibiotics, systemic antibiotics, so on and so forth. So this shows the overall success rate of the patients treating with pramcrolimus or tacrolimus. Steroid sparing effect is definitely seen with patients who are being treated with pramcrolimus. Pramcrolimus patients used tacrolimus for a medium of 7 days, try corticosteroids for a medium of 7 days as compared to 175 days in patients of topical corticosteroids. Now, among the two, pramcrolimus and tacrolimus, which is superior, which has more acceptability, we find that pramcrolimus certainly is much more superior to tacrolimus, 0.03%. If you are treating patients with head and neck, whole body, however, the comparison is almost the same, but if it comes to the softer areas, here we find that pramcrolimus cream has a super advantage when it comes to comparing with tacrolimus ointment. Patients reporting adverse effects not much seen, however there may be some amount of erythema or irritation, itching or warmth or stinging sensation may be seen, but in pramcrolimus again this is definitely reduced because of the non-greasy formulation preparation of the pramcrolimus. Acceptability of pramcrolimus versus tacrolimus. Pramcrolimus is preferred by patients compared to tacrolimus ointment. Non-greasy and it was clearly preferred by patients compared to tacrolimus, 0.03%. It is suitable for facial lesions, suitable for soft lesions because of easy to apply, non-sticky feel and easy. Site burning is definitely noticed, but in some patients, however, this site burning is definitely much more when you compare it with tacrolimus. Penetration is again, if you find pramcrolimus and tacrolimus, we have good penetrability and there is higher lipophilicity of pramcrolimus as compared to tacrolimus. Systemic exposure of topical calcium inhibitors. Tacrolimus 0.1% was detected in 36% of blood samples. However, pramcrolimus is detected in only 12%. Systemic exposure to tacrolimus 0.1% higher than that to pramcrolimus. So it is much more safe. There is safety profile is much more of the pramcrolimus if you are comparing it with tacrolimus creams. Similar percentage of atopic individuals in both. Most frequently reported patients with nasopharyngitis, pyrexia, bronchitis, otitis media, diarrhea, upper respiratory tract infections, and cough and cold. Low discontinuations due to these, it is seen about 0.6% if you are trying with pramcrolimus. However, it may be 1.1% if you are trying with tacrolimus. No difference in growth rates between the groups, and there is normal development of infantile immune system. No case of lymphoma has been reported. Risk of cancer with tacro not supported by any epidemiological data if you check on this. So there has been guidelines for recommendation of atopic dermatitis, which says the first line already discussed moisturizers and emollients, then topical steroids, potent topical corticosteroids have to be avoided in the areas of face, flexure and genitalia, and tricalciferol inhibitors like pramcrolimus is preferred less than 2 years of age and in the areas of face, flexures and genitalia. In severe, this is coming to pertaining to a treatment of mild and moderate cases of atopic dermatitis. In severe cases, however, cyclosporin, azathioprine, phototherapy or methotrexates have to be added. Adjuvant therapy definitely remains the mainstay of the atopic dermatitis patients. Atopic dermatitis is common skin condition and has major impact on the quality of life of patients and their families. Evidence shows that pimecrolimus should be recommended as the treatment of choice. Recommendation is based on overall efficacy, patient preference, and soft safety profile of the patients for treating such areas. And tacrolimus tricorticosteroids are definitely considered unsuitable for sensitive areas. This is what you see if you are treating a patient of topical corticosteroids for longer duration. There may be skin atrophy, then striae, all these complications, thinning of the skin, so on and so forth. Various topical corticosteroids which have been used over all these years, they have, according to different areas, used hydrocortisone, which is supposed to be a milder one, is definitely considered relatively safe for children's skin or in the soft areas, whereas mometasone is a potent which can be used but only to some duration and to some extent. Effect of topical corticosteroids: there is reduction of stratum corneum, which again is a reason for rebound after the discontinuation of the corticosteroids. There is alteration of the lipid lamellae. Flare again is noticed, and scrotum and eyelid skin, as you have seen, is very sensitive, so there is increased risk of side effects when it is being treated by corticosteroids. Phobia is again there. It is highly there these days. Patients who come to you, they go and Google a lot. They know all the side effects of corticosteroids. So if you are starting with corticosteroids, again because of phobia, your patient doesn't improve, and there's a lot many other problems which can dermatologist can face if you are treating your patient with corticosteroids. However, there is still a need for corticosteroids in sensitives. If there is still a need for topical corticosteroids in mild to moderate cases, we have to treat, but we cannot go for more than about week or 10 days while treating, and later in severe cases, first treatment is made and then they can be switched over to the other lines of treatment along with normal measures which patients have to follow. So tacrolimus and pimecrolimus remains the mainstay in atopic dermatitis, and it also has shown that pimecrolimus can reverse the topical corticosteroid atrophy in about 46% of the cases. There has been studies. So calcineurin inhibitors, coming to a conclusion: effective treatment, well suited in long-term treatment, no impairment of epidermal barrier, no skin atrophy, and there has been no causal link between the use of calcineurins and recurrence of lymphoma or any skin tumors. This, as you can see, soft areas like neck, very well treated with pimecrolimus. Acceptability is very good. 85% of the patients almost cleared the lesions of atopic dermatitis. More than 94% patients cleared of facial atopic dermatitis, and 1% cream has substantial steroid sparing effect. So thank you so much for your patient hearing.
Thank you so much, sir, for such informative and simplified session, sir. I am sure that it will help healthcare professional to treat their patient very well whenever they are treating and handling the patient, those who are suffering from atopic dermatitis, sir. Sir, there are some questions. It has come from audience. I am taking one by one, sir. The first question, it has come from Lucknow. It was asked by Dr. CSP Singh. What is the role of antibiotic in atopic dermatitis, sir? Do you find any role of antibiotic in atopic dermatitis?
There's definite role of antibiotics in atopic dermatitis. See, if it is a mild form of atopic dermatitis where there is mild itching, erythema, then certainly we don't prefer antibiotics. But if patient is suffering with moderate form of atopic dermatitis where there may be loss of skin barrier, there may be chances of superadded infection, then certainly we have to go for antibiotics so that patient doesn't get with superadded bacterial infection, and we can control the agony of the patient at the earliest.
Thank you so much, sir. Second question, it has come from Nagpur, Dr. Jyoti, she has asked, Sir, what is your experience about the moisturizer which usually you recommend to treat your atopic dermatitis? Sir?
Am I audible to everybody? Because I can see there's a message that people are not able to hear me. Am I
Sir,
audible to everybody, please?
yeah, you are audible. It was written at 3:17 p.m., sir. So you are audible to us, sir. No issue, sir.
Okay. Okay, fine, fine. Okay.
Can I repeat
See,
the question once again?
moisturizers remain, yeah, moisturizers
You may
remain a
go ahead.
mainstay of treatment. Hello?
Sir, you may go ahead, sir. No issue.
Moisturizers remain a, okay. Moisturizers remain a mainstay of treatment of atopic dermatitis. It may be in any forms, any stages. See, a simple coconut oil, parachute coconut oil works a wonderful moisturizer because main aim is to, prevent the disruption of the skin barrier where the normal protective coating of the skin has to be maintained. So any moisturizer which is available, which is easy to procure, can have a good effect. It may be in the form of a normal aloe vera cream, aloe vera, normal aloe vera. It may be in the form of Vaseline white petroleum jelly, which is available in the market, which may be smell free or perfume free, coconut oil, or any other form, shea butter, coconut butter. All these form wonderful moisturizers while treating atopic dermatitis.
Thank you so much. A very interesting question. It has come from Dr. Imran. It is from Srinagar. So he has given you a lot of options in the treatment of mild to moderate atopic dermatitis in adults or children patients. What do you recommend as treatment of choice? TCI first, or steroid first, or as adjuvant treatment?
See, first line definitely is good moisturizers, good emollients. But again, coming to the stage, what stage the patient has come to you. If there is mild form, I think emollients and oral antihistamine should definitely work well. But if it is in a severe form, then I would definitely strongly go for steroids. I'll go for oral steroids also, and I'll go for mild topical steroids also wherever it is recommended, so that we can earliest reduce the agony of the patient. Once the patient stabilizes, once the patient is improved, then we go to calcineurin inhibitors like primecrolimus as already discussed, and so that we can have a better form of reduced exacerbation. Then in some patients, if that also doesn't work, then I definitely go for cyclophosphamide. Cyclophosphamide is drug of choice. It's a wonderful drug where there are minimal side effects, but at the same time we have to again go for all the blood investigations, all the blood parameters. We have to go for LFTs, KFTs, so on and so forth. And if again, lastly, Dr. Imran, if patient is able to afford, then we must promote biologics, because biologics are supposed to be very, very safe, and taking injections about say once a month can definitely lead to better remissions for the patient.
Sir, in continuation of the query which was raised by Dr. Imran, that you have addressed it regarding the biologics, sir. One question, it has come from Ghaziabad. Dr. Mohit, he has asked, can biologics can be safely used in during the COVID situation, sir?
Biologics, again, I said for COVID patients, what the age of the patient is, that's very, very important. Then, further, if it depends how much is the severity, we have to weigh the severity, because then if you talk about COVID times, even giving topical oral steroids, even giving methotrexate, even giving cyclophosphamide, all these are again immunosuppressants. So that is again a definite, you have to be sure that what you want to achieve and what you want to prevent. In case patient is healthy, patient is under 45 years, 50 years of age, and healthy, and respiratory wise we have full clearance, then there's certainly, I don't think there's, and more so if patient is taking full precautions of the COVID, that is not coming much in exposure with other people, is not moving out much, working from home, then we can definitely go for biologics. Yeah.
Thank you so much, Dr. Ramanjit. One more question. It has come from your city only, and Dr. Poonam Jha, she has asked, what is your experience and importance of patch and prick test? She is asking about the diagnosis of atopic dermatitis.
Patch patch test, patch test, at least I'm not doing. Some people, they go for patch test, but otherwise there has definitely evidence of a relation of food intake with atopic dermatitis. What all things are can lead to flare of atopic dermatitis. So in a way, there are other tests like allergy test, what we do, comprehensive allergy test for food panels. So those at times can help to some extent. I'm not saying fully 100%, but to some extent what your patients can remove in their diet, and with which all things they can be of some help to your patients. So patch test, prick test, I am not doing these days, so I don't have much of idea what we gain out of doing these tests.
Yeah, usually
But
that
food
test.
allergy test, definitely I feel.
Okay. Usually,
Yeah.
what I feel that those patients, those who are treating allergy, they used to do that type of test. Sir. That chest physician as well as pediatric pulmonologist, they prefer to use that type of test. Sir, another question. It has
Uh,
come from. Yeah, sir.
off
Sorry.
late, off late we have a very big list, which have to be do's and don'ts when by treating a patient of atopic dermatitis. Like, patients, they should be avoiding so many things in the diet, like which are like junk foods, then which all diets containing preservatives. All these things have shown a definite flare for atopic dermatitis. Then to some extent there are other diets like banana, it is helpful. Then nuts, it is again contraindicated for atopic dermatitis. So if we give a checklist to the patient, that certainly helps to the patients.
Thank you so much for clarifying her dot. Sir, one more question. It has come from Chandigarh, Dr. Vikas Sharma. He has asked, sir, what is your drug of choice in recurrent atopic dermatitis in maintenance therapy, sir?
In maintenance therapy, I definitely go for pancrolimus, and frankly speaking, I'm very fond of good emollients. If we give them repeated emollients, then definitely we can keep it under control. But once in a while, when that flare has to come, it definitely has to come. You may be giving anything for keeping it under control, then nothing works. So once the flare is there, again we have to go back to square one. If flare is moderate to severe, we have to give some amount of steroids for some time. Then if it is severe, we have to add antibiotics also to prevent superadded infection, or we have to add oral steroids or cyclosporin, so on and so forth.
Thank you so much, sir. One last question I will take. That this question has come from Delhi. Dr. Vishal, he is asking, what is your preference of TCI in immunocompromised patient, diabetic and cardiac patients, sir?
Topical calcineurin inhibitors, definitely there has been studies, and I've shown you the slides also, that penetration is very very less, and it doesn't give there are no evidences as such that it can give rise to any sort of systemic problems, or it can affect your diabetes or anything. I have not seen such studies till date, and I feel it's comfortable to use. Only thing is, once patient is in a stage of remission, then we should stop these, because we cannot give them for years together, 10 years, 20, 15 years together. That patient is using pancrolimus or something. But as soon as the flare is down, switch over to your normal moisturizers, emollients. Once again we find that the patient is again coming back with some amount of flare, again we have to start. So intermittent use can definitely balance your any unknown side effects also, which we cannot foresee also that way.
Thank you so much, sir. The same question, the one once again he has asked one more question. What kind of lifestyle advice should be given to the atopic dermatitis children?
Lifestyle advice is the foremost and most important part of treatment. Counseling is foremost important part of treatment. We have to advise them that such patients, they should be wearing loose cotton clothes. Loose cotton clothes, I said. because cotton, if you are wearing synthetic clothes, they tend to irritate your skin. Even in the winter season, because of excessive dryness, and winters are known to have a flair for atopic dermatitis, we should advise them that they should be wearing cotton clothes. On top of it, they can wear woolen clothes, but woolen should not come in contact with direct skin, otherwise they'll be giving rise to more of irritation, itching, and so on and so forth, and again there'll be a flare of this. Then they should be advised that they should avoid more of dusty environment, because dust also again tends to aggravate the your atopic dermatitis. Then they should be having a normal healthy lifestyle. They should be doing yoga, because mental stress again is a triggering factor for atopic
Right.
dermatitis. So all these things, if kept in mind, and you have to explain that they have to live with it more positively, they take it, they'll be more into a phase of remission. So these things certainly help for atopic dermatitis.
Uh, no, there. I don't see that there is any question. Once again, I am checking it. Uh, Sir, the one question it has come, it's not related with directly the topic that he has asked. Another thing which is related with the psoriatic patient, sir. Dr. Deepak Srivastava from Delhi. He has asked, how do you counsel psoriatic patient regarding the diet, sir?
Psoriatic patients, regarding the diet, uh, I don't know, but I feel that if they avoid junk food and if they take more of a healthy diet, it certainly helps in their psoriasis remissions. Then apart from that, again, mainstay remains, you have to tell them that they should not be taking, at times we ask them that they should avoid pickles, fast food, all these things, because these things are definitely harmful for any eczemas. It may be psoriasis, it may be atopic dermatitis, or generalized eczema, or erythroderma. And so these healthy lifestyle and eating good food, even at times, there have been studies that fish oil is very good. So use of non-vegetarian diet certainly helps. Use of eggs at times certainly helps, because there will be protein. So high protein diet, which includes cheese, also can be added in their diet, which gives a better well-being to the patient, and patient feel more comfortable. Along with this, then zinc and the high potassium diet is again a sort of little win-win situation for both psoriasis and atopic dermatitis.
Thank you so much, Dr. Ramanjit, for such an informative and live session for all of us. I am sure, and you have clarified all the doubts that the audience are having, sir. We are thankful for your informative session, sir. And on behalf of Mylan Dharma Care team, once again we are thankful for your precious time which you have given to us, sir. Thank you, sir.